We've got about a minute till we're going to start. Well, now we're going to have to start because it got so incredibly quiet in here. And it's time. You know, this session, I would like to say from my perspective that this session was perfectly planned to follow what you heard about New Orleans. And I'm sure someone carefully planned that. It just happened not to have been me. So we have to look to other members of the planning committee. But we're going to talk a bit today about foundational capabilities and minimum packages of state and local health departments, predominant focus on local health departments. And after you heard about the journey that New Orleans has taken from, was it 1855? When was your charter? Yeah, in the 1850s to very recently get into the 21st century, the same question that we need to be asking ourselves. We are now in a post-health reform world. So we are moving on in terms of what health looks like in the United States. What then is the public health context for what public health should look like? What is the minimum package that public health services should have for every citizen or every resident in our country? What are the basic programs that need to be in place to assure that those public health services can be delivered in an efficient and an effective way? So we're going to start that discussion this morning with our three speakers. And we're going to start from the context of the work that the Institute of Medicine Committee on Public Health Strategies to Improve Health, their work, and it was chaired by Marthe Gold, who will give the perspective of the work that that committee did that she so capably chaired. We will follow that by looking at the current work group on minimum packages and foundational capabilities and how we cost that out, and Glen's going to give us that perspective. And then we're going to come down to, what does that really mean for us on the ground level? And we're going to use Ohio as our case study for that, and Jason's going to give us a perspective from Ohio. Let me just put in a couple of words that you may not know about each of our speakers that I think is pretty important. Marthe was not only a spectacular chair of the committee at IOM that produced 3 reports, the committee, the report on investing in a healthier future, which came up with these concepts we'll be talking about today. But in her free time, I don't think she actually has any free time, she tends to write plays. So Marthe is a playwright, and you can ask her questions about that in the time we have together. Glen is rapidly developing a reputation for being the preeminent public health systems and services researcher in our country, and it's always great to hear about what Glen is doing his work on. But what you may not know, if you were up usually at 4:30, is that Glen runs a marathon most mornings on his way before he goes to work. So if Glen wasn't a preeminent researcher, he would be a preeminent runner. Jason, quietly over there, is turning the state of Ohio upside down and leading us to what the future of what public health will look like in the 21st century. But that's just his day job. At night, he is working very hard putting together some of the things you're going to hear about into a dissertation as he gets his doctorate, I believe, in public health. So without further ado, let's get Marthe at the podium and be thinking about the questions you have, because we've got a little time for interaction, hopefully, at the end.
Thanks, Les. I'm very pleased to be here. Before I start, I wanted to have a couple of disclaimers. I'm fine with the sort of theoretical aspects of public health practice, but I have no dirt under my fingernails, and so I want, as people listen to this talk, you'll get a sense of what the committee grappled with as we put forth our ideas about the 3 reports that issued, but I'm going to leave some of the thornier questions to my colleagues as we go through. So, the IOM Committee on Public Health Strategies issued 3 reports on measurement, law and policy, and on funding. And I'm going to glancingly refer to the first 2 reports, But primarily I'm going to talk about what's in the funding report, which is the most recently published one, came out in 2012. Just to note, the Institute of Medicine was the home for these reports, and it's the arm of the National Academy of Sciences, and most of you will be familiar with their work in sort of advising various components of the nation on ways to improve health. The study was commissioned by the Robert Wood Johnson Foundation, which has been so instrumental in improving the public health, pushing the research and practice agenda. The project ran from November 2009 to April 2012. We had 3 deliverable reports on measurement law and funding, and the committee was constituted by 18 different people from public health practice, from law, from clinical medicine, from quality improvement, primary care, health economics, data management. It was a very varied, rich, and therefore feisty and contentious committee at different times, but it was a delight to work on. I'm joined here today by 3 of the members. Les was on the committee, Glen was on the committee, and Dave Ross was also on our committee. So I gather from Dave that you saw this slide yesterday. This is a really important slide for all of us to sort of keep our minds on. You can see here, again, where the United States falls on the sort of cost and value curve. We are 24 out of 34th in life expectancy in OECD nations. We're 30 out of 34 in terms of infant mortality outcomes, and there we are, lonely way out there, spending a huge amount of money per capita, obviously not gaining a lot of value for the health care that we're providing. So this enormous cost that we spend in the healthcare sector creates an opportunity cost that allows us not to be able to invest as well as we might in things like housing and education, in environment, and other things that we in public health know are actually the real determinants of health and where we could get enormously larger bangs for our buck. We also interfere with our competitiveness in the international marketplace. So we need to figure out how to fix this problem. And clearly some of this is going to come in the medical care delivery system. We need to eliminate unnecessary and inappropriate care, of which there is a lot. We have to hopefully get our costs down. We need to limit administrative costs. We need to make sure everybody gets into the system at appropriate times so that we can catch things early. But key to the committee's considerations, we're thinking about implementing population-based prevention strategies, and we thought about that really in the context of governmental public health agencies. So just to tell you how governmental public health-centric this group was, the chart that you see on my left, I don't know where it is over there, on your left, which is the Public Health System IOM report from 2003, has in the center in the green, it says assuring the conditions for population health, and it puts everybody around the circle as partners, as equal partners. So it looks at academia, it looks at the media, it looks at employers and business, it looks at healthcare delivery system, the community, and governmental public health. Everybody sort of centered around there. What this committee said is, you know, it's not that governmental public health is the most important in creating health in the country, but it is the one that is really charged with, has the mandate to care about population health. And it is the convener, and it should be the knowledge organization. And so this committee moved governmental public health to the middle of the circle and arrayed all of the other actors around it. So, assuming that governmental public health is going to really take on that charge in the next part of this century, and the committee was actually asked to envision public health systems going forward into the next 20 years. We wanted to make sure that all public health agencies really had the capacity to deliver on that vision. And clearly, public health statutes and many health departments don't lay out the breadth of new kinds of responsibilities that public health agencies need to bring to bear. So the committee in its law report recommended that states enact legislation with appropriate funding, and we begged that question for the moment in the second report, to ensure that all public health agencies had the mandate and capacity to effectively deliver the 10 essential public health services. And I'll come back to that in just a moment. And also, there was the acknowledgement in that report that public health agencies had lagged far behind other entities in accrediting it themselves, and therefore telling the public, telling the policy community that they were capable of delivering the things that everybody expected to come from them. So in that report, the committee also endorsed the notion of revising laws to require accreditation through FAB. The difficulty with the 10 essential public health services and the core functions of assurance of accountability, of assurance of policy development, is that there's not enough specificity to get your mind around when you're actually trying to reorganize in the way that we just heard about from New Orleans. And so in the third funding report, the committee talked about the importance of developing something that was more pragmatic and more easily described both to the public and to the people who would need to fund these agencies. And it came about that it thought about a package of foundational and programmatic services that would be available, that the public would understand was there to protect and promote its health, that could serve as a framework for program management, for performance evaluation, and for accountability. And importantly, the idea was that this package would be able to be linked to financial data, to capacities, to processes, to program and policy development, and ultimately one could look at the flow of money and the outcome results and say something useful to it as one both changes programs and builds capacity to bring programs to scale. Now, the committee was not actually constituted to say what was going to be in this minimum package, but it wanted to be able to conceptualize this idea. And so in the third report, we lay out some ideas about basic programs, programs that most of you will have in place in your departments already, in maternal and child health, in substance abuse and mental health, in infectious disease control and chronic disease, environmental health. We left open what all of those programs might be. But the important piece that seems to be missing because of bad funding kinds of situations are the foundational capabilities that kind of crosswalk all of these different programmatic areas. And I know that through the funding streams, through the categorical grants, through the 1 year at a time kinds of sensibilities that happen in federal and state and local funding, it's difficult to strategically plan. It's difficult to build programs that have a sort of a strong capacity to interact with one another. So communication isn't just about maternal and child health, it's also about chronic disease. Health planning isn't just about environmental health, it's also about infectious disease. Information systems need to be able to crosswalk, partnership development, policy decision support, research and evaluation. All of those things need to undergird the categorical programs that a health department puts together. The committee laid out this framework and asked that we move forward and have other stakeholders come together, and I think Glen's going to talk a little bit about how that thinking is progressing on the ground about a minimum package. So also about the minimum package, there's no standardized method for collecting and reporting information about funding streams and costs of program delivery by public health departments, and our last speaker was, I think, very explicit about the difficulties of trying to figure out where the money was actually coming from and where it was actually going. So one of the things that the committee became interested in was this notion of a chart of accounts, and this was not a familiar term to me when I began this process, but I've become much more sensitive to its importance. The financial accounting systems used by public health agencies are very idiosyncratic, and they vary from one jurisdiction to another, and often they sort of take on the template of what's demanded by local and state kinds of accounting systems. And they're designed really for fund accounting, but not for overall financial and program management, which is really necessary for understanding, what you get for what you put in. It's also meant that there's been a dearth of comprehensive and consistent financial data on the nation's health departments, and the committee had a lot of difficulty scraping together the data that we did have in terms of costs of different kinds of, and investments in public health. So Peggy Honoré and her colleagues noted in 2007 that public health agencies typically lack an operational framework for basic levels of financial analysis and research. A uniform chart of accounts that tracks revenues and expenditures would provide a reliable basis for studying how variability in use of resource leads to differences in process and interventions, and how that leads to differences in outcomes. And it's going to help local public health departments make more informed decisions about how they allocate their resources. So the the chart of accounts was considered to be a really important accompaniment to the minimum package, and that the idea would be that the model chart of accounts would be developed, again, by outside stakeholder committees for all public health agencies in order to track funding on programs and outcomes from their agencies. The committee also described a range of needed research, both on the public health services delivery side, as well in the areas of causality, effectiveness, and the economics of population-based interventions. It noted the extremely low investment on the research side for population health and asked that HHS develop a research agenda and infrastructure and a really dedicated stream of money that could really push the research agenda further. A pittance of money goes into public health research at this time, and the committee sort of, while it didn't put it explicitly into a recommendation, sort of noted that the kinds of industries that need sort of rapid change typically devote about 15% of their expenses to research and development. That is clearly not what goes on in the public health sector. So moving on, and again, it's kind of wonderful to follow the New Orleans talk, because a lot of that was sort of prescient in coming forward with some of the things that the committee was thinking about. The committee realized that we needed to have stronger collaborations between public health and clinical care, and certainly as the IT systems kind of ramp up and are more present in the medical care delivery side, a sort of interaction with a flow of information to public health will allow local public health and state public health to be a lot more canny about what kinds of problems exist in the community. So we need to have a sort of bidirectional flow of that information. In the measurement report, the committee said that governmental public health was in a good place to be a sort of honest broker in local levels to help people develop an understanding of the distribution of risk factors that were in the communities, but also to heighten public awareness of the performance of their medical care delivery system, what was going on in terms of overuse, underuse, appropriate use, what was the efficiency of the health system that was in their neighborhood. And as you begin to report on these things and visibility gains becomes greater, then pressures to change become larger, and the committee thought that was a very important thing. So in the context of the clinical care issue, and this was a very fraught kind of discussion around the table for probably a year or so as to what to recommend in terms of drawing back from clinical care service delivery, because so many public health departments certainly have, for many, many years, for all of their existence, been direct service providers. But the committee felt that as coverage increased through the Accountable Care Act, and obviously it's not increasing as much as we had hoped, as quickly as we had hoped, and obviously there's some problems by all of the recalcitrant states that have decided not to participate in the Medicaid piece. But putting that aside, we hope we're on a trajectory where most Americans will have health insurance in the foreseeable future. And as that coverage increases, it's really, we thought, important for public health agencies to stick to their knitting and become the sort of knowledge organizations that, and the sort of conveners and the sort of thought engines about the health of populations, and to stay home and do that kind of work rather than one-on-one individual care, which is expensive and is a distracting kind of area of effort on the part of agencies. I talk about this because I started my career as a clinician, as a family medicine clinician, and any time I tried to do something that was more of a thoughtful piece, there was always a patient clamoring at the door. So in a sort of institutional perspective, I understand how that interferes with your ability to sort of move forward in sort of broader efforts. So the committee recommended that health departments work with clinical care providers to develop adequate alternative capacity for clinical services outside of health departments. So I'm going to just talk a little bit about money. Where does money come from? Because obviously that's an issue. So I'll go back to this slide that shows us our poor value, and note to you that the first recommendation from the committee out of the funding report, and we put it up front deliberately, was that the Secretary of HHS set national goals on life expectancy and per capita health expenditures that by 2030 would bring the U.S. to average levels among other wealthy countries. And we used average to be provocative because the United States is always happy to be the best at things. And what it would take to get to average would be a lot of heavy slogging, both on the health outcome side and on the money side. 50-year-old women would have to add, assuming that there was no change in the other countries, 1.2 years of life in order to get to average. And to get to the top of the heap, we would have to add 4.2 years for women. For men, the numbers are 1 year to get to average and 2.3 years to get to exemplar status. And so that's a challenge, but we need to get there. How are we going to deal with cost? Well, the IOM had another important report that came out a year or two ago that talked about the amount of waste. Perhaps 30% of the spend, the $2.5 trillion spend at that time, was considered to be unnecessary, excessive administrative costs. Below, they credited $105 billion of prices that are too high. That was before this amazing report came out in Time magazine by Stephen Brill that really suggested that there's some real price gouging that makes me think that the numbers are way, way higher than that. But point taken, there are ways that we can trim costs, and we could take some of that money, such smidgens of that money, and put it back into the public health population system and really get a lot more money for our buck. So this impoverished-looking tree is your public health department of today. This is courtesy of David Fleming, who was on our committee. He made the case early along in our discussions that it's great every year. There's the Christmas presents of the categorical programs, and the branches get nice and plump, but the foundation, the trunk, is just always impoverished, and it leaves people in very difficult situations for strategic planning and program development. So some numbers. In 2011, government public health spending was about 3.1%, or $77 billion of our spend. What that reached in terms of thinking about per capita costs was over $8,000 in the medical care side and $251 on the public health side. States and localities give very different amounts of money to support public health efforts. The committee found that at that time in Nevada, there was about $3.40 per capita being spent on each individual, whereas in Hawaii there was about $170 per capita. So that's a huge difference about what you can do for that kind of money. The other thing the committee became aware of was how really relatively small the federal contribution was to the public health infrastructure. At that time, about 15% of public health agency funding was coming through federal investments. And when you think and you turn your mind to the Medicaid and Medicare side of things, where the federal government, between those two programs, puts in about 83% of the support, you have to ask the question, why should the federal government think it would be less important to have a vigorous population health infrastructure in place in every community than it did to the medical care side? This is the kind of lopsided thinking that has gone on, and hopefully we will begin to make the arguments that begin to change things to the better. And all of you know, I don't have to tell you how funding streams have been very unpredictable, they've been inadequate, and they're largely inflexible, so that you can't sort of cross over between programs, and so you have different data sets that get maintained for maternal and child health and for infectious disease, and there's just sort of no sense to that. So how do we find some money? Okay, so one thing, again, heartening to hear from New Orleans, The idea was that as healthcare reform advances and health departments give up taking care of individual patients, that money be liberated, preserved, and be reinvested into population-based programs. And that obviously is a strategy that you need to figure out how to talk to your local folks about to be successful, but that's a really important place where money could be found. But also the committee asked for changes in federal funding mechanisms. HHS was asked to create greater state and local flexibility in the use of grant funds, consistent with local population needs, and to recognize in their funding the cross-cutting foundational requirements of public health agencies. And again, this is a tricky time. We're living with sequester. Programs have all been cut by 5%. You know, where is this all going to come from? And Congress is also asked to institute legislative changes that would increase the flexibility of government funding streams so that programs can be better intertwined. And similarly, public health agencies were asked to think about incentivizing coordination among public health stakeholders so that smaller entities would not be competing against smaller entities, and that there would be some sharing and building of capacity. But having said all that, current federal fundings for public health fall well short of what one needs to allow departments to function smoothly in fulfilling duties. So governmental public health needs adequate funding in order, if it's really going to deliver this minimum package of services that we've talked about. So the committee had some very interesting testimony from various experts in the area of how do you get money, how do you squeeze money out of a rock kind of situations. And in the report, there are a lot of different strategies that are discussed, but what the committee said was important was if we're going to find a way to get money, we should look for a source that has a meaningful connection in the public and legislative eye to the health of populations. We want to be able to raise sufficient funds from this source, and we want to make sure that when we tap this source, we're not going to create sort of deleterious economic problems in some other part of the world. And for that reason, the committee recommended that Congress establish a new funding source by enacting a national tax on all medical care expenditures. So this got reported, and we got scolded a fair bit by some of the more conservative media, you know, what new taxes. But in reality, what you would need to get the $12 billion that the committee suggested would be the sort of initial phase of what we would like to see as an investment, which would double the current federal investment, would be essentially 0.5% on the medical care delivery transaction. And we felt like that was just kind of like a little sprinkle of salt that nobody would actually ever notice. Obviously, this has not taken wings yet, but we are ever hopeful. So we never knew exactly how much money was needed. We looked in every source of data that we could figure out as to how could we possibly prognosticate, but we didn't have good enough financial data. Hence chart of accounts would be really important. We need, therefore, to have a strengthened public health research enterprise that can help us know what amount of money we would need in order for a minimum package to be rolled out. Groups are now working on thinking about minimum package, about costing, and Glen is going to talk a little bit about that and how one might begin to cost out a minimum package. And then finally, when we get there, it would be really interesting and important for the country to begin to think about where we really want to invest. You know, if we're putting 97% of our money into the medical care system and 3% into population health, that doesn't seem like it's the right mixture. But what would be the right mixture, and how do we develop an evidence base that really describes what that might be? So here you go. Here's your tree. It's all nourished, and we're hoping that 10 or 20 years from now, all of the health departments will look like that. That they will be leaner in terms of their clinical delivery function. They'll be more policy-oriented. They'll have a different array of capacities. Accountability will be greater. There'll be more collaboration, particularly in the smaller health departments where there needs to be a lot more sharing in order to be able to accomplish some of the things that are envisioned to be available in every community. And that health departments will be adequately and sustainably funded by flexible, coordinated, and evidence-based funding. Is that my bell? How perfect. So there's the website if you want information about what's in the other reports, and thank you very much.
Wonderful. Well, Glen Mays, again, thank you so much for the chance to join you today and to be a part of this conversation on this panel. I'm at the University of Kentucky. I had the privilege of working under Marthe's leadership on this committee over the 2 years that produced these 3 reports, and with Les and Dave Ross and others. And had I known how much especially this 3rd report on funding, was going to dominate my life and my work, after our committee's work was over, I maybe would have given some further thought to some of the deliberations and recommendations that were made there. I think many of us thought that we were, at the end of our 2-year term on this committee, we were passing the baton to the larger public health enterprise to go forth and actually do the work to implement recommendations. But for those of us like myself who are applied public health services and systems researchers, some of these recommendations have begun to dominate the questions that we're being asked to answer now. There are certainly federal, state, and local public health agencies who have risen and been galvanized around these recommendations and are doing remarkable work to make progress in implementing them, and that have pulled those of us in the research and academic community with them into helping to answer these questions. And I know this is a conference about quality improvement. This is a conference not just about studying but enacting. But I know that if I look across the room, there are many of you who are closet researchers, part-time researchers, and practitioners who are journeying along with us in this effort to actually make progress in some of these recommendations. So even just that one recommendation that Marthe mentioned, to identify the components and the costs of this minimum package of public health services that could be made and should be made available across the country, has stimulated a lot of important work over the last year since this report has been out. And so I'm going to share with you a little bit of my perspective about what's happening in the kind of applied research arena around shedding some light around the components and the costs of that minimum package, spending maybe a little bit more time on the cost estimation work that is ongoing now, but also I'll share with you progress that's being made alongside that in identifying the components, some of the more important components that need to be a part of that minimum package of services and programs and foundational capabilities. And thinking about the cost, the work, why is it important for us to get a better handle on the cost of delivering high-value public health strategies? Again, I think this morning's session, hearing about the work that has taken place in New Orleans already helps to answer that question. But we know that there are enormous problems that are driven from just the fact that we don't know, we don't have good information about the costs of delivering public health, nor do we have good information, as we know, about the cost of delivering health care more generally within our health system. But poor information about, there's ample evidence over time in the U.S. and abroad that having poor information about the costs of our work really continues to distort decision making and kind of locks us into a spiral of poor decision making, poor management, and poor implementation, ultimately helping to produce that disconnect between what we spend and the amount of health that we produce with our investments here in the U.S. But without this information, we can't manage and improve the work that we're doing. Again, the focus of this meeting around quality improvement, having good cost information is at the heart of doing effective quality improvement. We're obviously not able to link cost information to process improvements or to outcomes to again identify opportunities and inform decision making. We can't, without good cost information, we can't identify and eliminate the waste and inefficiencies and the cross subsidies that are hidden within our public health and healthcare systems. And then we also we're unable to create the kind of incentives, the rewarding efficient and effective delivery and correcting inefficiencies. And so not having good cost information, not knowing the cost requirements for delivering effective public health programs and services is a big deal. And fortunately, there's some great work now that's happening to correct and to make progress on this. Having good information about costs allows us to align spending with preventable disease burden. It allows us at least to see that how the extent of the disconnect between what our opportunities are for preventing disease and injury and where we're currently spending our dollars and making our investments. It helps us identify more precisely the inequities in public health resources and how we deploy them across states and communities, across risk factors and health improvement opportunities. It helps us identify opportunities for improving productivity and efficiency, major targets for the quality improvement movement in public health. It helps us, very importantly, demonstrate value, again, by being able to link spending to outcomes. And this has been, we know, a major hamstring for the public health enterprise and our inability to make the case with the public and with policy decision makers about the value investing. Having this information will actually allow us to build better fiscal mechanisms, better mechanisms for generating the dollars and for targeting the dollars to places that can actually create more health. And so the efforts to make progress on that IOM recommendation on identifying the components and the costs of this minimum package of public health services is these are some of the powerful benefits that are at play. Marthe mentioned already some of what we know imperfectly about our cost and resource use within the public health enterprise in the U.S. We do have a national health expenditure account system that is maintained in the Department of Health and Human Services. It does track public health, governmental public health expenditures are one of the items that it tracks. And we know that those are imperfect estimates. What we think we know, as Marthe mentioned, maybe about 3 cents of every dollar spent in our healthcare system goes into public health and prevention. That probably represents about a 0.5 percentage point of our gross domestic product in the U.S. Just decimal dust in terms of our total economic output. As that blue line shows you here, that level of spending has been pretty flat over the last 2 decades, despite the fact that we know we've seen enormous changes in preventable disease burden, a huge continued growth in chronic disease burden in particular, but yet very little movement in terms of our overall expenditure. And as Marthe mentioned, where the money comes from, again, this is what we think we know, at least at a national level, that we're heavily reliant on state and local funding sources. The federal government is a minority investor when it comes to investing in the public health enterprise. But we also know our current data systems, our current ways of estimating the costs and the resource uses in public health are certainly imperfect. And while these numbers probably aren't too far off at a national level, because errors tend to cancel each other out when we aggregate across the country, when we try to drill down to state and local levels to understand cost requirements and investments and then track those to outcomes, we see much wider variation, and we run into just the absence of information that can drive informed decision making. Again, we also know that there's wide variation in resource investments and levels of investment and levels of expenditures on public health programs and services across states, across local areas, as Marthe mentioned. And a lot of our work that we undertake in the public health services and systems research enterprise is really about helping us to understand better the causes and the consequences of this variation in spending, particularly the health and the economic consequences of a variation in spending, so that we can identify the opportunities for improving health and for bending the cost curve that exists within our public health enterprise. And while we're making some progress in that arena from a research perspective, we're hamstrung again by our limited ability, our limited methods and tools for understanding cost requirements in public health. So again, there's been some really exciting work that's been stimulated really just over the last 10 to 12 months, triggered in large part by those recommendations in the IOM report. Some of this work has focused squarely on cost estimation in public health, and I'm going to just give you a quick tour of some of this work. Basically, and we've got some good methods that come to us from the larger field of health services research around how to estimate costs. We can use prospective methods to basically expert panel methods to elicit cost resource requirement expectations from experts who are involved in the day-to-day work of public health delivery. We can do concurrent studies to actually go out and observe actual resource use in real-world public health agencies and programs by doing time studies and activity logs and direct observation work. And we can do retrospective studies, use cost accounting methods to use existing data flows, existing records to uncover the costs that are attributable to public health programs and services. And we've got studies underway now really using all three of these methods to, again, shed greater light on the cost requirements for delivering core public health programs and services. Again, these methods have been widely used in the health services research arena for a number of decades now. They're how we arrived at some of our current models for costing and paying for medical care delivery, like this study from Bill Zal, who he studied back in the 80s, that created the underpinning for our current payment system for physician services here in the U.S. Or methods that have now been used to precisely cost out the cost requirements for delivering substance abuse services through the federal SASCAP program and under the Substance Abuse and Mental Health Services Agency. And even methods that we're using within Medicaid now to cost out public health agency roles in performing outreach and enrollment activities under Medicaid, which are obviously of heightened importance now with the Medicaid expansions, at least in about half of our states that are about ready to take shape now. So we already have experience with these methods in health services and even in public health delivery to a limited extent. Some of the challenges we face now in applying these methods to identify costs in public health delivery relate again to some of the complexities of our public health delivery system that were many of which were identified in the IOM report that Marthe toured for us. One of the big issues is in delineating state versus local roles and division of effort in terms of who bears the cost of public health delivery, what share is a state versus a local responsibility. And the challenge, as we know, is that share and that division of labor varies widely from one state to the next. We've got to take account for that in costing out these services. Identifying and understanding scale and scope effects in terms of the delivery of public health services. A lot of the work that we do in public health entails fixed costs of implementing surveillance systems, for example, or laboratory services. And so in places where we can spread those fixed costs over a larger population, we see larger returns to scale. And there are also important synergies that exist across public health programs and services and in many cases an array of programs can utilize a core set of personnel or services. And so there are economies of scope in the delivery of public health services in many places. And so we have to take account for that in the work in costing public health activities. And then another important area relates to identifying important attributes of the output of public health programs and services. The fact that the intensity of delivering public health programs and services can certainly vary across programs and across agencies and states and localities. Again, a major focus of this conference is understanding quality differences in public health delivery, and that can play a major role in cost implications. And then thinking through the reach of public health programs and services as well, how that varies and how that reach affects cost requirements in public health can be critical. In looking at the work that's now taking place across the U.S. to identify cost requirements and identify, again, the components of a minimum package of public health services, there are three efforts underway that are particularly influential that we're working with. Washington has been a real leader, not surprisingly, in this work to identify components of this minimum package of services and to cost out these services through Washington State's Foundational Public Health Services initiative. Ohio has been another leading state, and I'm not going to give a lot of detail to Ohio's work because we're going to hear from Jason here in just a minute about the great work underway in Ohio. And also Colorado. I know we've got a number of partners from Colorado who have been involved in their state's core public health services activity that was triggered by the kind of a landmark state legislation passed in that state back in 2008. And so very important work is underway in all three of these states, both to identify the components of this core package of public health services and foundational capabilities, and then to cost out or identify the cost requirements for those services. And these projects are all now informing a national work group that has been brought together by the Robert Wood Johnson Foundation and by the CDC, ASTO and NACCHO, and several other of our national public health organizations. To identify a process for now identifying that package of foundational public health capabilities, and for identifying the cost requirements associated with that package of foundational public health capabilities at a national level. And so let me just step you through a few more brief examples of some of the work that's happening under these projects and how it's filtering up to this national work group effort. Again, in Washington, Washington has been through a very deliberate process to identify a set of core public health services, very much in line with the IOM recommendations that include these foundational cross-cutting capabilities, as well as a set of basic public health programs. And very recently, the Washington Public Health Improvement Partnership has completed at least a preliminary estimates of the cost requirements of delivering both those foundational capabilities and those basic programs across the state of Washington at both state and local levels. They used largely prospective cost estimation methods, and so rather than looking at what the state was currently spending in these activities, they said they went through a deliberate process to say, here are our aspirational goals, here are the level of delivery that we would like to achieve in the state of Washington, and then asked experts both at state and local levels of the public health system to then estimate the cost requirements of delivering of implementing or realizing those foundational capabilities and programs at those different levels. And while these are just preliminary estimates, the work that has come out of this the partnership suggests that you can see the bottom of this slide. The per capita estimate for local public health spending to deliver these foundational capabilities and programs is about $24 per capita, and with the state contribution of being about the same level, because in Washington there's a relatively equal division of labor between state and local in terms of financing public health delivery, and so some important preliminary estimates about cost requirements for delivering these core capabilities and services across the state of Washington. Ohio's been through a very similar process, and again, I think we're going to hear from Jason here in a minute more specifically about Ohio's work to first identify what's in this minimum package of public health services with regard to both foundational capabilities and core programs. And interestingly, there's a number of parallels to what Ohio has identified that's in their minimum package and what Washington decided to put in their list of core capabilities. And Ohio has also been through a process to actually now to develop a model for costing out these capabilities across the state of Ohio. Ohio's work, at least that's identified in this slide, has focused specifically on the local public health contribution. And again, Jason will probably be sharing with us more details here. But Ohio's estimate essentially suggests that the local, on a per capita basis, the local contribution on average across the state works out to about $32 per capita to deliver this minimum package of public health services and cross-cutting core capabilities. And as I mentioned, Colorado has also been through a parallel process, again, to identify a set of core services that include both foundational cross-cutting capabilities and a list of essential programs and services that are have now been defined in state rule as of October 2011 in these areas that you see here. And through the great work of our Colorado Public Health PBRN, the PBRN there has been through a recent exercise to identify current levels of local public health expenditure in these core areas. Here, Colorado used primarily a retrospective methodology, looking at current levels of investment in these core areas, rather than a prospective process that Washington used. And Colorado's estimate works out to about $37 per capita, local public health spending of about $37 per capita to deliver these core services and cross-cutting capabilities. So again, as I mentioned, there's also we're learning from the work of these three pioneering states, and also we've initiated a parallel set, some new studies to kind of fill in the gaps around some of the cost requirements for public health delivery through our Robert Wood Johnson Foundation Public Health Practice-Based Research Networks program. Just earlier this year, we launched a set of 11 new studies through our PBRNs to provide an even more detailed estimates of cost requirements, and to look at variation in cost requirements across different types of public health settings at both state and local levels. These projects were just launched about 2 months ago, and again, Jason is involved in one of those projects in Ohio. And these projects, as they play out over the next 12 to 18 months, will help to shed even more light on cost requirements for core public health delivery. Ultimately, a lot of this is still a work in progress, and as the work that's happening, that's playing out at the local and state levels, are feeding into the deliberations that are now being made at this national work group around identifying components and costs of core public health delivery. I think there's still a lot of learning to be made in this work, but we're making very good progress. So I'm going to stop here and turn it over to our third speaker, who I think will be drilling down into an even finer level of detail around what's happening in the great state of Ohio.
Okay, so we've started real broad. We've begun narrowing down, talking about financing. Now we're going to talk about what it means for local health jurisdictions to actually try to come up with a package of minimum services as described in the IOM report. And I start off with this lovely picture of making sausage. Some of you may be familiar with the old quote from Otto von Bismarck that laws are like sausages, you don't want to know what goes into it. And our development process was actually very similar. We think that this should be a practice-based process. That's what we intended, but really for local health departments, particularly in Ohio with our structure, practice and politics are inevitably linked. And so we spent more time dealing with the fallout of the politics and what was driving our process sometimes, and actually spending our efforts in getting what is best in the interest of everyone concerned, and that's good public health in Ohio. So the process that we're going to be talking about is known as Public Health Futures. That was started by the state's SACHO, the Association of Ohio Health Commissioners, in the fall of 2011, and it completed and issued its report in the summer of 2012. And so as we look at the critical incident timeline I've included, you will see that the release of the IOM report was during that process, and you'll see some of the language out of the IOM influenced the final decisions we made in regards to that report. So, first off, 3 things we're going to look at, and we'll go fairly quickly through some of these, but it's helpful to look at the context of Ohio's decentralized public health system to get a feel for it, because that definitely influenced what the minimum package was. We want to review the process we used to gain consensus around the minimum package, and then we're going to talk a little bit about the actual core package itself. So Ohio, as with many other states, while 100% of the population of Ohio is covered by a local health department, we have more local health departments than we do actual counties, because cities can form their own local health departments. So as a consequence, we have 125 local health departments at any given time. And as you can see, our traditional old population centers in Northeast Ohio, that heavy manufacturing district, coal district, generated the most sort of legacy health departments, and they still exist to this day. Now, new health departments have the potential to be formed every day. They do not. Back in the 1990s, Ohio had almost 200 local health departments, but we've consolidated down to about 125, and we've been fairly stable with that number, seeing one or two consolidations, or I'm not sure if this is actually a word, deconsolidation. Occasionally, the politics drive a health department to split back apart, and we actually had that where we had one health department became three within the last 3 years. So while occasionally we see a consolidation, it is not unknown for Ohio to see separation, a segregation of a health district. When we look at the health departments in Ohio, like most of the country, the majority of our health departments are smaller than 50,000 population. We have a handful of sort of the mega health departments, the ones that are serving well over 500,000 folks, but as you can see, the majority are serving less than 50,000, and then we have a mix of those in between. Ohio is a decentralized public health system. Generally speaking, it has a board of health that is appointed by elected officials, and then, of course, the health officer, or you'll hear me refer to health commissioners. Health commissioners is that combined role of the director of the local health department and the health officer or chief health officer for a jurisdiction. Those are appointed then by the Board of Health. You'll notice the state is not involved in this process. And it is a decentralized health system. In Ohio, what we end up with, and this is very, very critical to the way health departments function, is theoretically we are separate and distinct from partisan politics, right? We shouldn't be influenced by partisan politics at all. However, we are influenced by our constituents because we're funded by our constituents. Public health funding in Ohio is local, and we'll go into more detail with that. So in their infinite wisdom, the legislature, when it created Ohio's public health system, did actually separate out county government from local health departments. So local health departments are actually a separate and unique part of the state's political unit. We are not under the State Department of Health, nor are we under county government. We are a separate entity altogether. And that has huge implications for how we are funded and what influences our decisions. And you'll see that in the core package. In terms of contextual factors that influence the development of the core package and the Public Health Futures white paper that we produced that describes all this, one, of course, is ACA. As we're going through this, the question of what is the implications of ACA on local health departments. It was unknown at that time. I think largely it's still unknown at that time. Now, obviously, the IOM report's recommendations speaks to local health departments getting out of clinical services, but then what? How do we get to the population-based services? How do we fund those population-based services? What is our interaction with local providers? And that was unknown, and certainly those are questions that are still unknown with ACA's implementation. We have FAB, of course, is on everyone's mind and has been for many years now. But in 2011, when we began the report, the beta tests were finishing up. We had folks about to be the first accredited health departments in the country, and that was certainly on top of everyone's mind at the time. Then we were in the midst of a recession. We saw reductions in both state and local government funding, and certainly grants that fund a lot of local public health were disappearing. And then the last one was real and truthfully political pressure. We had the newly elected Governor Kasich. And Governor Kasich had a little word when he created the Office of Health Transformation he liked to call innovation. They were going to innovate public health in Ohio. Now, public health has many, many meanings. Typically, as a local health officer, I think of public health meaning local governmental health. But for the Office of Health Transformation, a lot of what they were targeting was Medicaid. They were really going after that big gorilla in the room that was costing so much of the state budget, and they wanted to see reform. However, if they had left and stuck with Medicaid, it would have less influence on what we ultimately came up with. Because the director of the Office of Health Transformation, Greg Moody, who's very, very smart at what he does, was publicly talking about reforming local public health. And he said, that challenge went out in a public meeting, we are coming after you in the next budget bill. And that makes a difference, because the hidden agenda that most people thought that meant went along with Governor Kasich's innovation phrase. They made no effort to hide their agenda of reducing the number of units of local government in Ohio. And so regionalization and consolidation were the two things that most folks thought of when they heard reforming local public health. So that led to the development of the AOHC Futures Committee. we actually bartered an agreement with the Office of Health Transformation, said, give us some time and let us work through a process to come up with how to reform local public health, and we'll give those recommendations back to you. And they agreed. So that was a very good sign. And so that's the process that we began. And you can see some of the highlights are on the critical incident timeline. Of course, the IOM report occurred during this. And as the process unfolded, we actually went from the white paper into a legislative subcommittee into budget recommendations for the biennial budget bill. So the original vision that the committee members had for this report didn't talk about a minimum package at all. It simply didn't. It was focused on government, it was focused on structure. The closest we get to a minimum package in the vision that the committee began with was that Ohioans are assured of basic public health services. As we went through the goals of the project, explicit goals of the project, structured governance, funding, and collaboration were why we put this report together. Structure and money, because that's what everyone routinely in local public health, at least in Ohio, I can't speak for other states, but in Ohio, that's what we complain about the most, right? We don't have enough money to do what we're supposed to do, and the structure interferes with our ability to be flexible in how we spend our money. So that's what the purpose of the project was. As we go farther down the goals of the project, eventually we get to one little single solitary phrase that says, oh, and by the way, we should probably talk about what the minimum capacity of public health is. It seems kind of like an important thing, but it wasn't at the forefront of our mind. So let's talk a little bit about how that package evolved then if we start off with a project to look at structure and governance. So the steering committee. The steering committee of this project was made up of 17 AOHC members, so basically local health officers, plus the executive director of our SACHO. And then we reached out to the Health Policy Institute of Ohio, who is a policy analyst firm. They're very well respected in Ohio, including the governor. Greg Moody actually was on their board before he became the director of health transformation, so he had ties to them. It seemed like a good maneuver politically. And again, they were well respected with the legislature. The legislature used the reports that came out. So we contracted with them. We had funding from 3 different charitable organizations who gave funding to the project, and then the SACHO kicked in the remaining portion of it. Health Policy Institute of Ohio did reach out to Patrick Lanahan, who is another analyst in Ohio, an attorney by trade, not to be confused with Patrick Lanahan, who's with UIC. The report had 3 phases. One thing that came out very quickly in all 3 phases of our research was the idea that we actually have to talk about the minimum standard that we expect every Ohioan to have in terms of public health. That wasn't a goal of the project, but it very quickly became clear that that's what we needed to do. So part 1 was pretty much a descriptive review of what Ohio's public health system looked like, regulatory and environmental scan of what's going on, and then an online survey of AOHC members regarding current collaboration. Remember, regionalization and consolidation was a huge factor driving this process. So we surveyed our members to see what's already happening in regards to this, because there's some belief that we are doing cross-jurisdictional sharing already, it's just no one's tracking it. The second part of our research process involved key informant interviews. Now, all 17 committee members plus the executive director of the SACHO were interviewed as part of this, as well as some members of the State Department of Health, the Governor's Office of Health Transformation, and a couple of key informants who are researchers in cross-jurisdictional sharing. Matter of fact, I think one was in attendance this week. This also included a literature review, primarily focusing on regionalization and cross-jurisdictional sharing, as well as performance. Some of the work, Rex Santari's work, became very influential in this report and caused a lot of heartburn, actually, as things unfolded. And then the second part of this process also involved subcommittees of the steering committee to really focus and drive down on some of the categories we were looking at, like regionalization and consolidation, like minimum standards, like funding. Key informant interviews. As I said, 25 total were conducted, the majority local health officers. Because this was a local health officer-driven project, there was an intent from the beginning to really make it about and get the structure of it completed using just health officers and their experience. Ultimately, that probably was a mistake because it created difficulties with buy-in later on. But there was a lot of trust issues going into this project, and sometimes you just can't get past those, and you have to do what you have to do to get the project moving. So 17 health officers, 1 executive director for the SACHO, and then 7 members with broader appeal. The last process that we engaged was, of course, census building. And AOHC has regional health officer meetings as well. For 5 of those, we had the research team went out and did consensus building with those, presented the report, what their findings were, talked about the recommendations that were coming out, and got feedback on all of those pieces. We also had an all-member meeting to do the same. And it was fairly well attended. I think we had 80 to 85% of the membership attended that meeting. So out of 125 people we were looking at, about 90 came to that meeting. And that's pretty usual. We have a fairly engaged membership in Ohio. We don't tend to have too many who stand out and don't become engaged, particularly on issues like this. Now, here's the first piece that has to be acknowledged. Everyone who went into the process, and the regional meetings, and the steering committee meetings, and said, there's not enough money in public health in Ohio, over and over and over again, pounding the table. There's not enough money in public health in Ohio. There's not enough money in public health in Ohio. We need more money in public health in Ohio. The problem with saying that, and I think the research bore this out, is money for what? We didn't have a standard understanding of what everyone should be delivering. So it's very difficult to say we need more money in the public health system without knowing what it's meant to pay for. And that came out in the steering committee meetings. Everyone wanted more money. What we found out is a lot of money siloed. It's tied up in certain program areas. But to say we need more money or we need more flexibility, back to Martha's point, more flexibility in the money we have. And do we need a standard set of services that everyone's providing and cost that out, which again goes back to what Glen's talking about. And that came up eventually. So, a couple of pieces of evidence that we used to develop our final recommendation of core packages. The first one, and this is heavily influential, believe it or not. It may not seem that way at the front, but becomes very heavily influences what the final results are. And that is, where does our money come from in Ohio? Ohio is somewhat unique compared to a lot of other states. Our state GRF does not fund local public health in Ohio. We have federal pass-through dollars that you could say come from the state. You can make an argument for that. But it's really federal block grants that are then sub-granted to different health departments in Ohio. But to say that there's GRF going to local health departments is inaccurate. In my health district, less than 1% of my funding for operations comes from state GRF. For most health departments in the state of Ohio, 75% are locally generated funds. And that is a combination of levies, inside millage, and fees. 75%. I showed you earlier that health departments are separate political subdivision in the state of Ohio, but their boards are appointed by elected officials, and there's a financial tie with those same elected officials, because that's where we have to get the money from at a local level with inside millage. So what do they value becomes important when we start identifying that core package of services. What do our communities value in terms of what we do? What are the public face of public health in local communities? Because they're going to vote for my levy. And so that starts to drive some of our conversation. So it's hard to say the state should have a huge influence on what that core package is, for better or for worse, when they're not funding directly a lot of the services. And that definitely influenced our final decision. We also did take some time to look across the 10 essential public health services, and we did a crosswalk between those, what is mandated in Ohio Revised Code, what's permitted in Ohio Revised Code, and then what is funded in Ohio Revised Code. And you can see the green is explicit funding going to a program. You can see most of those are environmentally related. Birth certificates, death certificates. Statutorily, the fee is set, and we collect it, and it funds the operation. Environmental fees, statutorily set. All environmental programs in Ohio are done by local health districts. We have a cost methodology in state legislation that says what we're allowed to charge. It's collected locally, plus a part that's remitted to the state. So again, you're seeing money is influencing, to a large degree, what we're capable of doing at the local level. And that makes a difference then when we come up with our minimum package. So I said at the beginning, our vision didn't include anything about a minimum package. When we talked about the goals, we only had the barest hint of a minimum package that we want to talk about. But now when we get to the 19 recommendations that are issued in the white paper, 7 of them, the first 7, all talk about the need for a minimum package that covers 100% of the population of Ohio. And so you have this evolution from our original goal was on governance and structure, and now all of a sudden we're talking about this need for a minimum package. And it evolved from this, all these considerations we had. I have to say this one in particular will stand out in a moment. One of our recommendations was that all local health departments should be eligible for FAB accreditation. We valued FAB. We thought that was an important piece. And it's very political, but we said they should be eligible to apply for FAB recommendation. And those of you who've gone through the process, most of you are aware of this, what those handful of documents and handful of things you have to have in place are. That's all we were shooting for in this report with that recommendation. So our final minimum package. It's basically conceptually has three areas. One is what's known as core public health services, other public health services, and foundational capability, similar to what you've seen in other states, similar to the language that was used coming out of the IOM report. Core services are those that all health departments have to make sure are being provided in the community. Foundational capabilities are supplementary things, not a service that's directly delivered to the public or in the public's health, but things that support those efforts. And then other public health services are those clinical, optional things that really a community has to decide whether or not their local health department is involved in that process, similar to, again, what came out of the IOM report. We look at those services and we can do a crosswalk and see that there was some deliberate effort to make sure that the FAB accreditation standards were met by that core public health service or the foundational capability. And if we walk through all 12 recommendations, you can see each one is met, at least in part, by what those minimums are. Now, the fallout. Not all 125 people were happy with this report. Go figure. Part of it was it was tainted by the regionalization consolidation because it's hard to be honest about what needs to happen in local public health without saying there comes a threshold where you should really consider consolidating health districts or you should regionalize health districts. And we had to put that in the report, that if you can't meet certain criteria, if you can't meet certain population limits, you should at least investigate that. And that created more than one enemy to the report. We had some of our own steering committees who didn't feel the report went far enough or was going the wrong way. And so they rebelled. There were efforts to recall the minimum package at one point. And ultimately, we had a couple members who went to the state legislature to try to get action on this issue, which then led to the legislative subcommittee. Directors of nursing, be kind to your nurses or you will burn. I know this for a fact. The directors of nursing, which in Ohio, all local health departments are required to have a director of environmental health and a director of nursing. The directors of nursing felt slighted by this report and felt slighted by the minimum package because we took the things that they most valued and said it was other. Not the best choice of words. Definitely not the best choice of words. So they really felt like we were isolating them from what public health should be at the local level. And so that caused long-term problems. And then legislative outcome. We had members who were upset and they were going to the legislature. We had a governor who wanted to see change in the Office of Health Transformation. The Office of Health Transformation was very complimentary of the report. And the legislative subcommittee went through and approved every single recommendation and agreed with every single recommendation and then issued their own report with specific legislative recommendations. So, one of those, though, was mandatory voluntary accreditation. It's a favorite of mine. We did have in there, everyone should be eligible for accreditation. That was true. But we also had, everyone should be covered by the core minimum package. Somewhere along the way, that became translated into, you will be accredited by 2018. Long-term implications, and then we'll finish the presentation. Because of this long, bitter legislative battle, all the naysayers of the core minimum package kind of fell away because it's the only thing we had to stand up in front of the legislature. So even though they didn't agree with it going into it, they had no choice but fall in line in order to protect themselves against the legislature. So it actually has sort of de facto become the core minimum package that we're supposed to be achieving. Now, it is not in legislation that way, but the State Department of Health and the Office of Health Transformation, as Glen showed on his slide, hold that up as this is what the minimum package should be. We did then, again, as Glen mentioned, resolved in a lot of work to look at what's it mean to fund that core minimum package? What does it mean to cost out those studies? And we've involved in 2 of those projects right now. Most health departments are looking at FAB, perhaps to the detriment of local public health to some degree because it's now a requirement. Local health departments are also looking at cross-jurisdictional sharing. There's deliberate efforts to increase that in Ohio to see if that helps reduce the cost of delivery of services and the ability to meet that minimum package. But the last thing that is probably the most damaging long-term is that too many of our small health departments are focused on the threat and not the opportunity that came with the report. They just see it as a way to get rid of local public health in Ohio if you're below a certain size. And that's causing a lot of long-term problems for us because they can't see past that, and they're not willing to work on ways to perhaps look at collaboration and sharing. We don't think anyone should be forced to consolidate because it's local public health. In Ohio, it is truly local public health. The state cannot force consolidation. It doesn't have that authority to do that, but it can do other things, and that's the fear. So long-term, good project. Very proud of the work that the committee I was involved with did with the white paper, and I think it's gained a lot of traction with the legislature and with most health commissioners in Ohio. But there's a long road ahead, and we still don't know how it's going to pan out just yet. So with that,
I'd like to thank our 3 panelists. Marthe, thank you for the very analytic overview that I think you provided for what all 3 reports, and particularly the funding report. Glen, I'd like to thank you for giving me several ideas for my next public health services and systems research project. Jason, the whole notion of mandatory voluntary accreditation is a little troubling to me as the incoming chair of the FAB board. Let me give that some reflection. I certainly get the idea of being kind to nurses. I learned that in residency. But I love the concept of more money for what. I think that's really going to be key. We don't have time for more questions, or actually for any questions right now. Our speakers will be here for a few minutes. Checkout is at noon, and then lunch. Are you guys going to be here for a few minutes and at lunchtime? So they'll be happy to entertain your questions. You can even say things that are provocative to them. I think they'll want to hear your thoughts. Thank you all very much. And let's hear it again for our speakers.